Welcome to the Euclid Facebook live stream series. We're really happy that you're spending some time with us today, where we're going to be talking about a really interesting topic, office safety and cleanliness from both the clinician and microbiological perspective. We have two great guests with us today, Dr. Susan Resnick and Mr. Michael Ward, and I'm very excited to hear what they have to say about this particular subject. I'd like to introduce Dr. Resnick first. She specializes in the fitting of all different types of contact lenses in a highly successful practice in New York City. She's diplomated in the cornea contact lens refractive technology section of the American Academy of Optometry, the American Board of Optometry, and the Scleral Education Society. She's a valued consultant to the contact lens industry because of her in-depth knowledge, and she's kind of ubiquitous these days as far as lecturing and authoring on different subjects. Susan, welcome very much. Thank you for coming here today.
My pleasure. Thank you for having me.
Michael Ward achieved his Bachelor of Science degree in microbiology from the University of Washington, and has always been my go-to guy for anything related to contact lens solutions, bugs and crud, and those types of things relative to contact lenses. Michael recently retired from Emory University Eye Center, where he had served for a long period of time as an instructor in ophthalmology and director of the contact lens service, and highly valued specialty contact lens practitioner also. He has many different interests, but in particular that of keratoconus and the management of that with contact lenses. Also, both of our guests today have been recipients of the GPLI Practitioner of the Year Award. A very prestigious award, and that kind of says it all about both of these guys. Michael, you doing okay today?
Yeah, thank you, Greg. Thanks for the introduction. Thanks for the invite to be here. Looking forward to doing anything I can to educate about micro.
Okay, this is fantastic. You know, that it appears we're getting closer and closer to reentry from an overall national perspective. And facing a lot of challenges. And that's really what we'd like to talk about today, is that we all become germophobic and clean freaks, and, you know, managing our offices in such a way. We really hope that you would share your expertise in this area. And if we could, Mike, I'd like to start with you first. And can you just give us a brief description from a microbiological mind like yours of the coronavirus? How are they named? How are they determined? And how did we get to where we are today?
Good question. COVID, as we referred to it, is SARS-CoV-2, the official name of the virus that causes the disease COVID-19. By the way, the 19 means it was discovered in 2019. It's the coronaviruses, which is its group of viruses that it's part of the family of, is a large family of viruses, and up to, you know, until recently, in the last 10 years or so, it just was associated with mild respiratory diseases. It's a large RNA. Remember, viruses are either DNA or RNA, not both, with some protein, and this has a lipid capsule on it, which actually makes it easier to disinfect than if it didn't have a lipid capsule on it. It uses a hemagglutinin also to be able to penetrate and propagate in mucosal membranes. It's primarily spread by droplet method. How long that droplet is active on any surface is relative to how big it is. What are the environments, how dry it is. It doesn't like drying. It doesn't like being moist. It likes dry better than moist, excuse me. It doesn't like to be moist. It likes to be drying. It likes to be a dry environment, and it doesn't like heat. It likes cold, however. In fact, we preserve viruses in refrigerators, just to give you an idea. So don't think putting it in a refrigerator is going to do any good. It's not going to help at all. Its primary target is the epithelium of the lower respiratory system. So it wants to get into the lung epithelial cells. It can also infect macrophages down there as well. It's been associated with not just lung problems, but also kidney. A great number of these patients have kidney disease and are on dialysis, heart problems. liver problems, and also it can cause demyelination of the nerve fibers, so it can cause brain problems as well. So it's pretty toxic, and we're still learning a great deal. This particular COVID is much more infectious. It's spread more easily than the ones we've dealt with in the past.
Okay, great. That's a fantastic explanation. If I can just make the leap then to you, Dr. Resnick, instead of from just the microbiology end, as Michael just said, can you talk about what you know about its effects on the eye today? We hear stories about it might be related to conjunctivitis and might be an early sign, might not. Can you give us a bit of an update on the eye and this particular virus?
Sure. So there are a number of studies out, and each of them has, every study you have to look at critically. But if you look at the whole gestalt of all the studies, there's very little evidence that this virus can actually be transmitted from the tears. As a matter of fact, live virus has not really, there are some studies where they've isolated live virus from the tears, but it's been very, very small percentages. In patients who do not present with a conjunctivitis, a COVID conjunctivitis, and are healthy, or again, there's no way to really know we're healthy because we know now you can be asymptomatic and not and still be infected. But let's assume you have a 100% healthy person. There's no chance of that virus being in the tear film or the conjunctiva. So I think that if we think about this virus compared to something, let's say, like an adenovirus, it's far less chance of any contagion. So all proper precautions will need to be made. The heightened level of concern, and again, heightened being a relative word, is if somebody comes in and they are positive for COVID and have an active conjunctivitis, then yes, there is a slightly higher risk per se of transmitting that virus. But if you have all the proper precautions in place, which we all will, again, you are limiting your exposure risk. And we all took our infectious disease course. And so we know that you can break the chain at any point. And the idea is to keep that chain of possible vector transmission broken and not intact. But again, the chances, the study showed anywhere from 3%. There was one study that showed 30% of COVID patients actually getting the conjunctivitis. And again, the percentage of transmission was very, very low. The sightings were about 1%.
Right. Okay. That's fantastic. I would like to mention that I didn't actually say where you guys are from. Dr. Resnick's from New York City, right in the middle of all the action. And Mike is from Georgia, where they just opened up the state again. You couldn't get much more diverse than where the two of you actually live. Mike, if we could, in building on what Dr. Resnick just said, can you talk about what surfaces in the eye care office we should be worried about? Where can the virus settle? What really needs to have a lot of attention paid to it?
Yeah, good. First of all, primarily, remembering that we contract it by breathing it in, primarily. Other options include our hands touching a surface and then transferring it to a mucous membrane. Like probably the worst thing you could do would be like to pick your nose. Stick your finger up your nose with a dirty finger, because that's going to go direct right into the mucosa. Actually, going through the mouth, the mouth itself has many enzymes and organisms that want to kill it, along the way. It's part of our normal immune system. So you have to have an inoculum large enough. One virus can't hurt you. Your body's going to wipe it out. You have to have an inoculum large enough to actually cause the infection. So what do we worry about? What surfaces, to your question? Number one, think about just walking into the office, doorknobs, door handles, the counter, the pens, the countertop, any sign-in sheets that you may have. magazines in the waiting room, office furniture. You want office furniture that can be easily disinfected, that can accept harsher chemicals. If you have a coffee surface or a water surface, available to your patients in the waiting area. In the exam room, any surface, not just flat or curved surface, but any surface that may touch the skin or may be available to be coughed upon to have, because really it's coming from sneezing and coughing is where this stuff gets out of the body to infect the next. And what does a virus do? The virus's full plan is to get into your cells and create more virus. That's its goal, is just to multiply. And so it wants to get inside. So any surface that physically touches, it needs to be disinfected. So we need to disinfect, and pretty much there are many, many good disinfectants out there. As a little bit of an aside, Clorox was done really, really well during this time. Clorox wipes don't have bleach in them, which most people think, well, it's got to be bleach. It's got to be Clorox bleach. It's not. It's what's called a quaternary ammonium compound, which is very effective, but it's not bleach either. Bleach is probably the most effective chemical that we have, but it's also degrades a lot of materials as well. So most disinfectants can be used. 4-opters that can touch the skin. Anything that touches the skin, your chin rest, and everything from a keratometer to a slit lamp. Same with the headband. Again, any surface that's touching. I noticed that there's also some new shields out there to help protect the practitioner, larger than normal. The hog stripe, for example, has always had a shield there. But if you get too big, you can't get around it. Yeah. Be able to open the eyeball and do your work. So there's a limitation as to how large you can make this shield and still make it practical for use for the practitioner. When you use these disinfectants, you want to be sure you give it at least a minute to remain moist. So if you're spraying it, you want to be sure, or if you're using a wipe, be sure it's a wet wipe, that it's soaked long enough to stay on the surface, long enough to actually disinfect. Which brings up another question about when you wash your hands with soap, the soap is really, really necessary. The soap is necessary because that's what breaks down this capsid around the virus and allows it to, you deactivate it so it can't penetrate. And that's the key, because they have these what are called S proteins on the surface under a lipid film. And you got to break that down. That way it cannot penetrate, and therefore it can't get into your cells and multiply and so forth. How long it's valuable on surfaces? That can be anywhere from hours to 3 days that we know of right now. However, studies have shown that 90%, even in heavily contaminated hard surfaces, 90% are gone within 8 hours, 90% of the viruses. So it's a numbers game, in that. You're not gonna, there are viruses, of course, around us all the time, as there are all kinds of other, fungi, and as well as bacteria, of course, and protozoa and all sorts of stuff in the air, dust mites and all the rest of it. So you're not going to eliminate all the organisms. You really cannot do that. Right. The key is to mitigate it to where it's going to be a small enough volume that you can eliminate it.
So, Dr. Resnick, now that Mike Ward has efficiently scared the hell out of us with where this is, how is this going to translate into your office? Is you're preparing to get started again in the next weeks? I don't know the exact date, but probably at a longer time frame than many parts of the country. Will you be taking information that we just heard, like from what Michael's talking about with all the surfaces, and somehow the staff is going to manage that to make sure it's safe?
Yeah, we've been preparing now what we call our reentry strategy. As a matter of fact, we just had a Zoom conference with our entire staff yesterday to bring everybody up to speed onto the protocols. We actually plan on reopening within the next few weeks. Everybody is using what's called a soft start. So what that means is we're taking all the social distancing concepts and bringing them into the office, but also implementing the clinical disinfection concepts as well. So We have only one, so just to give you an example, in our larger office, we have a little over 4,000 square feet. So we obviously, if we bring in one patient every half hour, and we're only going to have one doctor working at a time for a 6-hour day with maybe 3 staff members, we're all going to be far apart. Obviously, the physician and the technician will be in less than the 6-foot distance at times to examine the patient, but those are going to be the only 2 individuals. There will be, let's say, myself and my technician will be fully bubble wrapped. No, I'm only kidding. We will be masked, gloved. Whether we wear shields or not will depend upon the individual patient. My opticians have chosen to wear one if they want to get close to measure the PD. So it's going to be a lot of really good clinical stuff, but common sense. Our administrative staff is going to be behind plexiglass. They will be gloved. They are going to be separated. There's only going to be 2 of them by 6 feet. The patient, if the patient, let's say, wants to hand a credit card, the patient will put the credit card down, go back, move away. The technician, the administrator will come and get it, or we're going to have a digital payments. You name it, we think we have thought of it. In terms of the actual disinfection process that Michael described, we are, our cleaning services have been given the products that we have chosen to use. They are hypochloric acid, hypochlorite solutions. There are a variety of different brands. They're going to be using that. They're going to be using surfactants first, as Michael mentioned, and the same thing happens when we disinfect and clean our contact lenses. You want to use a surfactant because you want to remove the debris, and it also breaks up these surfactants. Just remember where it comes from: surface acting agents. They are they have a lipophilic and a hydrophilic end, so they break up the debris using the soapy compound. You get it off, and then a final spray of our bleachy compound, and that's how we're going to disinfect all contact areas, bathrooms, exam rooms, counters, everything. So all of the science is going to apply to the normal, I'll use the word, household cleaning.
Right. So do you think that a lot of this will be what I call performance art, and in making sure that it's actually being done in front of the patient, so that it wasn't right before the patient came in the room, but it's when they're there, they can see it actually happening, so they can feel better about it.
So yeah, we call that, the good word is optics, performance art. So we actually kind of tossed that around. We were like, okay, should we clean the exam room? So we have a holding area where the patient can actually look into the exam room when the door is open and see what we're doing. And on a normal day, they're sitting there while the technician is cleaning after the other patient walks out, and then I bring them in. But because we want, we have the luxury of having 2 side-by-side exam rooms in each of our little coves, I'm going to change it up a little bit because I want it sprayed and air dried before the next patient goes in. So the patient will certainly be, if they don't see it, they're going to smell it. And so they are going to see that we have gone into that other room and it's being cleaned, but their room has been disinfected and dried. So yes, I mean, we have to do what makes sense from a more of a safety perspective than an optic perspective, but it will be apparent that everything they, has been cleaned right before they enter the room. Okay.
So Michael, what about, we've talked a lot about the stuff in the office and the surfaces and the staff, but we're contact lens people. So what about the contact lenses? How do you take care of the diagnostic lenses? In the office, for instance, in Dr. Resnick's office, of course, there are scleral lenses, there's GP lenses, there's hybrid lenses, there's soft lenses that are diagnostic and not disposable, possibly custom lenses. What is your suggestion from a microbiological standpoint?
Well, it really doesn't change much. I am a strong proponent of hydrogen peroxide, and I think it should be used on all lenses. And it's safe to use on all lenses. And hydrogen peroxide, because it's such a strong oxidant, rapidly will degrade the virus, very rapidly, almost immediately. The virus will be eliminated. So peroxide works very, very well. You need to, you've got guidelines on how to use peroxide. And the current guidelines say, 3 hours, which may not be necessary that's only necessary on protozoa. It's not going to be necessary for bacteria or viruses to eliminate them. That's going to be eliminated very, very quickly. And to Susan's point, at least as important is the washing to debulk and get the debris off the lens to keep it clean. And that alone is going to eliminate most virus.
Okay.
But the disinfection doesn't change. Again, I say hydrogen peroxide because it's such a great oxidizing agent.
So what about in particular, though? I mean, one of the common uses today in practice is the use of scleral lenses, or let's say even diagnostic Ortho-K lenses, it may be. And so if you treat them with hydrogen peroxide, then what? How do you store them? What do you do after that?
Well, if you're going through a normal routine of a diagnostic lens, after taking it off the patient's eye, from the previous patient, surfactant cleaning, rinse, disinfect with peroxide, and then dry, storing the diagnostic. We're talking about sclerals and GP lenses right now. Storing the lenses dry for long-term storage. And of course, periodically, you've got to recheck the parameters and be sure you got the right lens in the right case, which is whenever you're dealing with residents, that's a potential hazard, or multiple people opening the lens. As far as patients, again, I would still be using peroxide. Spare pairs of rigid lenses should be stored dry. Now, dry storage can create its own problems as far as wetting surfaces is concerned. But my experience is that if you clean it again and then wet it with the appropriate wetting solution, it comes right back. Dry storage is, as far as I'm concerned, is the gold standard for that. And organisms don't like to stay on that environment. They're not going to be viable for very long.
Yeah. Okay, Susan, what about lenses other than GPs? Do you have any other different technique that you would be doing there for custom soft lenses, for instance, or hybrids?
Yeah, so it's very similar actually. So for vialed custom soft lenses, for the diagnostic lenses, you're going to hydrogen peroxide them, and then you can rinse them with a multi-purpose solution or unpreserved saline if you want. We use the little glass vials that they come in, and we re-crimp them. We'll talk about how to disinfect those, but and then they get put into a multi-purpose solution. And theoretically, with all of the lenses, even lenses that patients store at home, you're supposed to re-disinfect them about every month or every 28 days, according to the 2018 ISO recommendations. So that's basically how we disinfect all of our diagnostic soft lenses. In terms of the little glass vials, you can boil them in water for 5 minutes, or there's also other things you can buy for in-office heat sterilization of those vials. And certainly for contact lenses that are 45% water or less, you still can put them into heat aseptors. Believe it or not, they're still available.
Oh, yeah.
So that's how we would deal with the soft contact lenses and the hybrids as well.
Okay.
Let me add something to that, correct?
Sure.
That what we used in the hospital situation was autoclave. So that all soft diagnostic lenses, not hybrids, all soft diagnostic lenses were cleaned with a surfactant, rinsed with non-preserved sterile saline, put back in the original vial with non-preserved sterile saline, crimped and autoclaved. And once it's autoclaved, it's good for a year by common hospital standards. And we actually, that's the best way to make sure you don't have and you don't have to worry about, is it 28 days later and I got to re-disinfect that? The staff sometimes will stumble over that part. Well, it doesn't seem like it's been 28 days.
Right, of course.
It may not get done.
And the benefit of that is that you don't, if there are patients sensitive to multi-purpose solutions, you can keep it in the unpreserved saline. We had an autoclave for years and years. Can't remember why we don't anymore, but
Exactly right.
it's
Chemical
terrific.
contamination is another concern.
Right, it's toxicity, right.
Yeah. So Susan, if you met with the staff, you said, and talking over your plans, are you going to do anything different during the application and removal teaching process?
So we talked about that. So typically we are very hands-on with our patients, and we're very chummy, and we would get close and the technician would sit right down next to them, make them feel comfortable, manipulate their hands, show them how to do it. We're going to be doing a demo. First of all, we're going to let them watch videos. There are excellent videos on YouTube. All of the major manufacturers put out great ones. So we have them on a little laptop. We sit them in the reception area. They're by themselves. They watch it. Then we will bring them into the room. We also have, you can laminate cards to put right on the desk, ones that are, washable, disinfectable, and give them one to take home as well. But in terms of teaching them side by side, we will put one, the patient at one end of the room, technician will stand at the other. Everybody's going to be masked anyway. So we'll be showing them. We probably just won't be manipulating them. If we have to, look, we'll go over. We're taking the precautions anyway. We've just did the exam. We don't feel like we're going to have that much more increased exposure if we have to, teach somebody, or at least show them how to position their fingers a little bit more closely. But again, we're going to limit. We're not going to be as close and chummy as we used to be, and rely more upon digital technology. We may even consider using a doxy.me. If somebody gets home and has trouble, or we feel like there's something where we don't want them to be in the office as long, if it's an older person or somebody who's immunocompromised, I will teach them the way I'm speaking to you right now, and we don't have a problem. It works very nicely.
Right. So those are excellent tips, and the telehealth part of that is really an excellent tip also. So Michael, regarding that, so I want to go back to the diagnostic fitting again. So as a clinician, you're going to have gloves on. How easy is it to balance and put in a scleral lens gloved?
Handling lenses, as you well know, with gloves on is not easy. We lose dexterity, quite simply, and we're used to balancing a lens, and you're used to maybe a 2 or 3 finger method to handle certain lenses. What about the DMV? What are you going to do with that? DMV, by the way, you can make them disposable. They're not that expensive, but you could also just drop them in peroxide, afterwards. Leave them in there for a certain amount of time, rinse them off thoroughly, and then reuse them. By the way, before you do that, it's a good idea to use alcohol first on the tip of the DMV to remove any. It's like doing the hand washing part.
Right.
Just remove any debris before you drop it into the peroxide. As far as diagnostic lenses, you got to use one. What's going to happen if you need to use that same diagnostic lens on the other eye?
Yeah.
Shouldn't be a problem on that patient. It's the same patient.
Yeah.
Really should not be a problem. But the way to do that is to take the lens again, surfactant cleaning, sterile saline, non-preserved sterile saline rinse, disinfect if you're going to. But again, if it's the same eye, that's less important unless you're dealing with a conjunctivitis or some other kind of ocular surface problem.
Okay. I'd like to remind our viewers, by the way, that we're going to be wrapping this up in a few minutes. And if there is any questions that anybody would like to ask of our guest today, to please write them in on Facebook to be able to do that. So let's see. So we've talked about what the virus is, what we're worried about in the office as far as the surfaces and the instrumentation and how to be able to manage that. We've talked about the performance art of cleaning things in front of the patients, and we've talked about taking care of the lenses. Other than maybe special advice to patients at home, is there anything else that we're missing here?
I'd like to just jump in and remind everybody that the good news about fitting contact lenses now, or at least the way it's going, is that your first lens order can often be made using empirical data. So many of the manufacturers, especially Ortho-K, Euclid, and a number of the other companies, you can just get your data, your topography, and you need not, I know that Synergize is going that direction now as well. So take advantage of topographical and empirical fitting, and it will definitely limit the contact and the contacts.
Yeah. Well, it sure takes away that whole diagnostic worry about getting the lenses in and going through the fitting.
I think we're going to see more of that.
Exactly.
Yeah. So, Mike, I have one last question. Does UV fit in here at any point?
Another good question. Ultraviolet light, UVC will definitely kill the virus, no question about it. But ultraviolet light C, UVC, which is the one you want to use, that 1 to 2 something nanometer wavelength, high energy, short wavelength, the spectrum of ultraviolet light. UV works best at short distances. For example, it's great for using at a micro hood, to disinfect the area you've been working in right afterwards. It's not so good on doing rooms because it obeys the law of inverse squares, and that is when you increase the distance, you got to increase the power and the time to be able to kill the organisms. We're not only talking about viruses here.
Mm-hmm.
And it also, UV light degrades materials, particularly plastics. So there are room UV lights that can be used that can go, I think the maximum is 16 feet, but if anything is shaded, it's not going to get disinfected.
Yeah.
It's not like having a gas in a room that's going to penetrate and kill everything. It doesn't do that. It's got to be in direct contact, and it works best at very short distances, actually, not long distances.
Okay, great. And then Susan Resnick, do you have any comment as we get a little closer to wrapping things up?
So my comment would be that there had been a lot of misinformation out there regarding the safety of contact lenses versus wearing spectacles. And we had to undo a lot of that damage because it came out from nowhere without any scientific evidence that spectacles offer any added protection. As a matter of fact, I can make an argument for the reverse. So I want everybody to keep that in mind, and I don't want their innate potential fear affecting the patients. I think everybody needs to just look, we're taking this seriously, but once you understand all the things that Michael has taught us, and you put the proper protocols in place, you'll have a more relaxed staff, you'll have a more relaxed you, and you'll have a more successful practice.
Well, that's great. That is actually the perfect way to end this too. So thank you so much. So Dr. Susan Resnick from a clinician end, Michael Ward from a microbiological perspective. What an interesting and an informative time we've had today. I want to thank all of you that are watching today and continue to watch these Euclid live stream Facebook series in the future. Thanks to both of you guys. Be safe.
Thank you.
Thank you,
Bye.
Craig.